Hey everyone, it's Denise Brown from the Caregiving Years Training Academy. Thanks for being with me. Thanks for watching. We're going to talk about an initiative that I'd love to start in November, which is National Family Caregivers Month. And I have been inspired to put this together over a period of probably 10 or 11 months, actually longer than that, but things started to come together for me in terms of how to talk about this particular issue. Last fall, I positioned us as family caregivers. So those of us who care for a family member, we comprise the world's largest group of healthcare providers. And then I started thinking more about being reimbursed for providing care. And my dad, who just died in July, received services through home health, palliative care, and hospice. And if home health didn't have a home health aide, for instance, we just figured it out, which led me to really start to think family caregivers are solving the direct care workforce shortage. We don't have enough healthcare workers, nurses, and home health aides or certified nursing assistants. And yet, as family caregivers, we just figure it out, like what happened with my dad. I requested a home health aide. When he had home health services, his visiting nurse said, and she was trying to not say no, but she just said, we'll try. And I said, you must have a shortage. And she said, yes. And we never did get a home health aide. We just figured it out. So that made me really start to think about how do we position ourselves as providers who are reimbursed for the care we provide? So I created a PowerPoint for you guys to kind of walk through some things that I think are important to know. And here we go. So we know there's at least 133 million Americans who have one chronic illness. The numbers are enormous. 133 million Americans. So who cares for them? So I have been doing this for a number of years. On an annual basis, I used to do a presentation called How Will We Care? I haven't had a chance to do it in 2023, but I'll do it in 2024, first quarter. And putting together that presentation for the first time in probably 2017 really made me think about, well, what are the numbers? How does the number of family caregivers stack up against others within the healthcare system? So look at it. I mean, we are the largest group of healthcare providers in the world. Amazing. And yet, think about all the other providers and systems that are not bulleted. They all get paid. We don't. So we're the 24/7 provider who is not automatically reimbursed. Everybody else gets paid. The systems, the individuals within the system, except for us. Now, there are some programs that do reimburse family caregivers, and I just wanted to mention them quickly. So for instance, if you live in a state where your caree qualifies for a Medicaid waiver program, so their income level is low enough to qualify for Medicaid, the caree might be able to hire you as their family caregiver and reimburse you for providing care. The state will determine how much you get reimbursed, and it's typically based on level of care, number of hours provided each week, and then that becomes your reimbursement. The Veterans Administration also has a program where the family caregiver could receive pay. And again, it's a program that the caree has to qualify for, and there must be a primary family caregiver. And then long-term care insurance could reimburse the family caregiver depending on the type of insurance that the caree holds and how the benefits are structured. So if there's a daily rate, for instance, that daily rate could be the payment to the family caregiver. So if we look at these programs, it's a minimal number of family caregivers who can qualify through any of these programs. And yet, we're the solution. So again, we don't have a home health aide for my dad. We just figure it out. We always just figure it out. So I started thinking about, what if a benefit like home health through Medicare can't function unless there's care from the family caregiver? What if that's the trigger then to reimburse the family caregiver through that benefit? Again, it could be a benefit like home health, palliative care, hospice care. There are other programs that have started to take hold. I would say they're still relatively new, and those are hospital at home and skilled nursing at home. And those programs provide almost like hospital level care at home for a caree, with visits from a staff, could be a nurse practitioner, a nurse, could also include telehealth visits, and typically there's a family member involved. So the family caregiver is doing 23 hours of care and not being reimbursed for that. Wow. The benefits are being reimbursed for providing care. So again, the trigger is, if the benefit can't be delivered without the care of a family caregiver, then the family caregiver should be reimbursed. Now, of course, we're talking about money. And if you think about budgets, especially if you think about Medicare, if you think about the healthcare system, they are strained and do not necessarily feel like there's extra money, except when there's a crisis. Okay, so let's talk about one particular crisis, and that is discharge from hospital to a skilled nursing bed. There are some hospitals that have such a significant backlog of discharges because there isn't a skilled nursing bed available that it can cost, can you believe this? $168,000 per inpatient case. In the emergency room, if there isn't a hospital bed or a bed in a skilled nursing facility, it could cost $18,000 per day. So the system is actually putting out money because of this crisis. So if a caree is scheduled for discharge, let's say on a Friday afternoon, because we know what always happens on a Friday afternoon, but there is not a bed available in a skilled nursing facility and your caree remains in the hospital cannot bill Medicare for those additional stays, those additional days. It costs the hospital when there is not a discharge plan that can happen. So in my research, I found this little tidbit. So there is a hospital in Washington that looked to solve this problem. So they had patients in the hospital who could not be discharged. So what they did is they actually gave money to post-acute facilities, like a skilled nursing facility, to help them hire more staff. So the hospital came up with $8 million over a period of 12 months, which they then gave to a skilled nursing facility so they could hire more staff. In addition, the hospital also paid their own staff to go to the skilled nursing facility to help with care. So they came up with $8 million, this hospital, because it was more cost effective than keeping the patient in the hospital. So you know what that says to me? When you need to solve a problem, you can find the money. Okay. What's interesting though, this is just an aside. Skilled nursing facilities are really struggling with their reputation because of what happened during the pandemic. So 70% of US adults say, I would not be comfortable being admitted myself or admitting a family member to a nursing home. So thought that was kind of interesting. So I started thinking about, okay, so what do we do if we know that these systems, like a hospital, are under stress because of all that's happening with the direct care worker shortage? What if we positioned ourselves as family caregivers as this collaborative partner? Now, typically when I think about navigating systems and working with systems as a family caregiver, I get really angry and upset and frustrated. And then recently I had an interaction on LinkedIn with a very nice person who, whenever I post about family caregivers, she always gives me a hard time, even though what I'm saying is really what she wants to happen. And she agitates at me. And I thought, we can't be the agitator necessarily. We want to be the solution. We want to be the collaborative partner, because I understand what it's like when I'm out there doing something that I feel is important and I'm advocating and I'm educating, and she will benefit from these efforts, and she still gives me a hard time. So we have to let go of the anger, because otherwise it's going to be, it doesn't create what we're hoping to resolve. It doesn't create us the opportunity that we want to be able to provide for the system. So that was something that I realized just a few days ago, that I have to let go of my anger, because I cannot repel. I want to attract. I want to position us as collaborative partners. So what if there is a program? Now, this is very high level. I haven't thought out every detail, but I wanted to just kind of say, let's imagine there's a family cares program in every community. And at the time of a caree's diagnosis, a family caregiver is enrolled in this program. Or when there's a medical event, like a caree is hospitalized, the family caregiver is enrolled in this program. Because that family caregiver is enrolled in the program, they start to receive training, coaching, and support. So you receive support early on in your caregiving experience. And then let's say there's like an enrollment period every October. We think about open enrollment for benefits as being in the fall. What if, as part of that, the caree selects or designates the primary family caregiver for the next year? So in some situations, it might be that there's a rotating list of primary family caregivers, which is a way for the family to distribute the responsibilities. Now, again, this is pie in the sky. Let's imagine what's possible. I know this isn't possible for every family, but let's just say this is a possibility. So when that family caregiver is designated as being that primary family caregiver for the next year, before the start of the new year, the caree and the family caregiver complete planning sessions so that they are ready with a plan in case of an emergency, like a hospitalization. Could you imagine if that was something everybody did? I mean, the hospital, I think, would really appreciate this, right? We've got a plan. We've thought through what the discharge looks like. We've thought through which community programs we want to use. We've thought through if it's rehab, which skilled nursing facility, if it's home health, which home health provider. We've thought through this because we've met with a certified caregiving consultant to complete our family emergency planning session. And it's done annually, and it's done before the start of the year. In addition, that designated family caregiver becomes a certified family care manager. So we have this program. It is about 4 hours of online training. It's all archived, and it's really around managing the experience. There's lots of great videos on YouTube, for instance, about managing hands-on care. But what we want to do is offer opportunities to manage the experience. And that's what the training really focuses on. And then when there's a hospitalization, there's the family care manager who becomes the point of contact with the discharge planner, with the staff in the hospital, and then immediately starts working on discharge plan the day after the first day of the hospitalization, for instance. So then at discharge, there's a plan. The caree returns home and then receives support and care from the family care manager, who now starts to receive payment through the home health benefit. So that designated family care manager, if he or she works, has already figured out, how do I take a leave of absence after a hospitalization? So they're not scrambling. They've already figured this out. So in the workplace, they've talked to their manager. They have information from HR about how to take time off, and they're ready to step in to provide that care as long as the benefit lasts. We did a special event last Friday on how to be prepared for taking a leave of absence. And that was very helpful and enlightening, because I don't think we ever really give ourselves time to think through, what if I need to take a leave in order to manage caregiving responsibilities? And I suppose we never think about it because we never want to do it. We don't want to talk to our manager about it. We don't want to have to figure it out. And yet, if we figure it out, then we're ready to step in. Okay. So what we need to do is create awareness and seek out partners. And I believe November is the opportunity for us to do that, because it's National Family Caregivers Month. So in an awareness campaign that we create, we provide you with templates of letters that you could send to the hospital in your community, to the American Hospital Association. We'll create social media posts that you can share across all your social media channels. We'll also create a petition you can sign. So let's use November as the month to create awareness and partners. And again, the awareness is around family caregivers are the world's largest group of healthcare providers. And we are the solution for the direct care workforce shortage. We've already been solving that by stepping up and stepping in. And in order to keep us as a group in a good place, we need coaching, training, support, and reimbursement. We've already learned what happens when we let healthcare professionals burn out. They leave the profession. We cannot risk family caregivers burning out. They are that critical to the systems, all of the systems. Okay, so we have a special group in our community called Caring Our Way, and the group is our caring, advocacy, and awareness volunteers. In this group, we share different awareness campaigns that we have managed and sponsored over the years. So that's where we're going to put all of the information for November. So if you'd like to join us, I'll post this link in the chat room. I'll also include it in the show notes below this video. We'd love for you to join us. And as a volunteer, you could do 1 hour in the month of November, and I would be forever grateful. I am not asking you to commit to 40 hours a week for 4 weeks in November. I'm really just asking whatever you can do to share, to create awareness would be wonderful. What we're trying to do is get momentum so that we capture the attention of the systems. And I think the first system is the hospital, because they are feeling the crunch. And it seems like, now this might not be an absolute, but it seems like there is a possibility for money if they need to actually solve the problem. Okay. So for those of you who have joined me live, what do you think? Yeah, go for it, Deborah.
I think this is a wonderful potential solution to 2 really important problems, as you mentioned, the compensation and training and coaching and so on. And I'm thrilled about that. My question, well, the issue that I come to this to focus on myself is the question of time, because I feel that the overextended consumption of time that caregiving often requires is the reason that caregivers, or a main reason why caregivers are stressing out, burning out, and sometimes dying before their caree. So I'm wondering how we would account for that in any compensation scheme. For example, my caree might need some specialized care, but I have to be still in attendance while that's going on. So it isn't a separate care matter for me. I'm still there and needed for certain kinds of activities, possibly during that care. So I'm hoping that what we're going to advocate for is that 24/7 compensation that so many people are needed, so that they could perhaps hire someone to stand in their place for that moment, so they could have an hour while the caree is being taken care of by a skilled professional or something like that, because we can't stretch time, we can't get it back. But I'm wondering how, how we can add that problem, or add that facet of the problem to this as well.
So one thing I think is important for us to remember is that we have to be reasonable about this. So what we have to look at are per diem payment rates that the benefit offers to other professionals. So for instance, if we were to look at the per diem rate that Medicare pays for a skilled nursing facility, and the caree goes home rather to a facility, that gives us guidance as to what percentage of that could a family caregiver receive. For instance, there are other programs that I looked at that are attached to Medicaid. So they're another version of a Medicaid waiver program, and they are in Georgia. So I looked at how they figured out the reimbursement rate. So there's a organization that manages the benefit and then pays out to the family caregiver. They receive a per diem rate from the Medicaid waiver program. Depending on which state, the organization might keep 50% and then pay out 50% to the family caregiver. So I think we have to be realistic and reasonable and know that we have to start somewhere. We cannot do this for free any longer. There has to be reimbursement rolled into all these benefits that a caree is already receiving, especially because it's the family caregiver that really is doing the work within the benefit. So that is what I'm thinking. We have to look at what's already out there in terms of what the payment models are, use that as guides to figure out what the family caregiver payment model is, and then figure out what percentage does the family caregiver receive. Knowing that, for instance, at home, it's not just going to be the family caregiver. It's going to be a visiting nurse. It's going to be a physical therapist, a speech therapist. So what does that look like?
Yeah, I think that per diem model is better. If we start looking at hours instead, then I think that's where we're going to come up short anyway, if there's a pot of money rather than segmented. So I agree with that. I think that's a great realistic place to start.
And the other model we could use is hospice. Hospice receives a per diem rate, and it's a little over $200. Hospice receives this per diem rate regardless of whether or not hospice provides any services that day for the caree.
Yeah, that's true. And I'm a volunteer for hospice, and so I understand that. I think this is a great idea, Denise, and I like that there are other models out there that we can maybe learn from and take advantage of, like that one in Georgia that you're describing. So maybe we don't have to start from ground zero to reinvent the wheel. But I particularly like the idea of raising awareness in November, because I do think that number, that 53 million number, is not top of mind for a lot of people. They don't understand it. They don't know it. And if we don't tell them that that's what it is, they're just going to go along thinking, oh, well, my sister can take care of my mom when the time comes, or whatever.
There were a couple things that you said that I found very helpful. And now I'm like, what was the first thing? So I'll just go to the second thing. And that is, so I've been going to conferences, and I went to a conference with home care providers. And what was interesting is they really focused on the direct care workforce shortage, but they really didn't talk about, well, who does the care if there isn't an available professional caregiver? Their solution is to create a group of home care providers in an area and exchange referrals, hoping that at least one, and it could be a competitor, has an available home health aide or professional caregiver. But they really didn't talk out, but wait a minute, what if there really isn't a direct care worker? What happens in that situation? They don't necessarily connect the dots that someone is picking up the slack, so to speak. It's not that the caree isn't receiving care. It's that the care is then provided from the family who's figuring this out.
Yes, yes. I think we're the invisible caregivers. We just, you know, taken for granted, not seen, not recognized, and not that we're not necessarily appreciated on a kind of, you know, basic level, family level, but from a statewide or national level, I don't think many people have a clue. And so if there's a template that's going to be developed, or if there's any kind of letters or anything, I'm all in for making waves. I think that's so important.
Yeah, I know what I wanted to mention. Okay, when I talk about the model in Georgia, which is a Medicaid waiver program, it's called Structured Family Caregiving. And I'll include links to the different articles that I've written, which include links to these programs. The amount of reimbursement to the family caregiver every day is not a lot. It's not a lot of money, which to me means there's money to be found.
Well, and I think that yes, there's money to be found, and maybe there are other ways that family caregivers can be quote unquote compensated. And I'm thinking now of things like if you think about childcare. Child care providers get tax credits. And so if family caregivers could get tax credits, that comes right off your bottom line taxes. So if you owe $10,000 in taxes and you've got $5,000 in credit, your tax is only $5,000. You know, not necessarily as good as a per diem, but helpful.
Right. Yeah, I do think there's different ways. And I also think that cash in your pocket is very comforting. If you don't have cash in your pocket, the weight of the world is even heavier. When you have cash in your pocket, you feel like you have some choice. You feel like you have some options. You see that that value is coming your way. It's a huge boost to your morale.
It is. Now,
yes.
With that Georgia program, do they pay taxes on that money that they get?
Right. So that's what I'm not sure. So there's a lot of details that I haven't quite figured out. One of the things that we talked about when we did the planning for your leave program last week is if you're going to take a leave and it has to be, for instance, through FMLA, which is unpaid. What if you had a system where your caree gave you a cash gift? And in 2023, an individual can give a cash gift up to $17,000, and there's no tax implications on either the giver or the receiver. And then that helps offset what you lose for taking, for instance, 12 weeks off. So the cash gift is an opportunity that I don't think a lot of people actually know about or pursue. And it doesn't have to be $17,000. It could just be someone in the family giving $5,000 to help that family caregiver for 6 weeks or whatever it is.
And I think that's a great idea. My question again goes back to, suppose the person, the caree, has to go on Medicaid in 3 years. Is that $5,000 going to be considered a gift that has to be considered in their Medicaid eligibility or not?
Right. So that my caveat always is talk to your financial planner, talk to your elder law attorney.
And
We
you
also,
can- yeah, you can do a contract that
Yeah.
says, you know, that takes it out of that gift consideration, but then that makes it not a gift. So it's there's some complications, but it's doable.
right, absolutely. And I think the investment in time with an attorney and time with a financial planner pays off. We do another free planning session every month, which helps you think through how can I get paid? So in my family, for instance, my parents paid my sister, my niece, and my nephew. And then I received payment later through an increase in the inheritance. So we think through, if there are no programs in your community that can reimburse you, how could you set up a contract with a caree who can reimburse you? And what does that look like so that you don't jeopardize Medicaid eligibility, you don't have tax implications, and you have cash in your pocket. You have an ability to save some money, to put some money away for your own retirement. The idea that caregiving becomes something that destitutes us is devastating. We should not have to live in poverty when we're providing care for our family members. And the idea that we're picking up the slack, we're the solution for the system and not being reimbursed for that is no longer realistic, practical.
Or acceptable.
Yes, that's the word, acceptable. It's not acceptable anymore. So I think about, for instance, if there isn't a home health aide and the home health agency receives a pocket of money for each patient, there's a pocket of money there's a percentage of that pocket of money that has not been spent on a home health aide.
Mhm.
Yet the money doesn't go to the family caregiver. The money stays within that pocket.
And what about the people that are in rural areas and don't have access to a lot of different agencies or any agency?
It's terrible.
That's they really must struggle.
I met with a home health agency in the state of Oklahoma when I was at this conference. They're a startup and they are very concerned about how to manage care needs in the panhandle. It's a very rural area. So how do they actually get staff to go visit and provide care? And it's really going to be the family members that do it, because there is no staff that's going to be able to drive 2 hours between client visits. It's impossible. It's impossible.
Oh, yeah. It's very hard.
Okay, so it sounds like we've got something. We've got to try.
Yeah, let's
Try.
try. I mean,
Yeah.
what's the worst that can happen?
We
Nothing. And then we're no worse off.
Right. We can't make it worse. I guess that's the way to look at it. We cannot make it worse.
Cannot make it worse. Mm-mm.
Yeah,
No.
so let's try. So I posted in the chat room the link to our area for volunteers who are interested in helping with advocacy campaigns. For those of you who are watching the archive, I'll put it in the show notes, and it is September 29th. So I have a month to get this all organized. And what I think I'll do is I'll get most organized before the start of November, and then I'll just keep adding in what we need. And what will be very helpful for me is as you start sharing across social media, what kind of response, what are people saying to you? Because that will help us with our message. What's resonating, what doesn't necessarily get the response that we want. That way we can tweak stuff as we continue.
Mhm. Okay.
Oh, and Deborah's got a question. Go for it, Deborah.
Yeah, is there a tag that would be best for us to use for you on LinkedIn and other social media?
So do you mean like
If I post a piece of art that you put up, how should I tag it so that you know it's there and you can continue to tag it?
Thank you for that. We'll use a hashtag. We'll create a hashtag for this campaign. I haven't thought of it yet, but I will in the next 4 weeks. But if you have an idea for a hashtag that you think would really be compelling, post it in our group. I welcome all suggestions and ideas.
Okay.
Okay.
All right.
Thank you guys so much. So appreciate your time today. And I'm looking forward to working on this with you.
Sounds good, Denise. Thank you for bringing it up and for spearheading it.
Yeah,
Desperately needed.
yes, fingers crossed we can make a dent, right? We have to start with the
Absolutely.
dent and then we become the crater, right? But we don't want people to fall through the cracks, so maybe that's not the right image, but you get where I'm going. You get where I'm going. Okay, everybody, thank you so much.
Okay.
I'll keep you posted.
All right. Bye-bye.
Thanks, Denise. Bye-bye.